Hello and welcome to the JASE Podcast Weekly Series. Editor-in-Chief Dr. Michael Picard, Managing Editor Deborah Meyer, presented by myself, Amr Jory. Today we will present two articles from the December 2020 issue of the journal. The first article is entitled Musculoskeletal Pain and Disability in Sonographers, More Than an Ergonomic Issue. This article is by Yanfei Xie, Brooke Coombs, Lucy Thomas, and Venerina Johnston. Sonographers, compared with their peer employees, are more likely to experience MSK pain, a problem of substantial burden. A recent report showed that MSK symptoms resulted in $6.6 million in working days lost. To inform the development of sonographer-targeted management strategies, in this study we aim to examine 1. The one-year prevalence and distribution of interfering MSK symptoms in the upper body in sonographers, 2. The association of individual work-related and psychosocial factors with the presence of multi-site interfering symptoms, and 3. The severity of neck-related disability. Between April 2018 and June 2019, we invited sonographers working within Australia and New Zealand to complete a cross-sectional online survey, excluding individuals performing sonography less than 4 hours a week, and those reporting current pregnancy, chemotherapy, or radiotherapy within the past 5 years, fibromyalgia, uncontrolled diabetes, or kidney diseases were also excluded. Ethical approval was obtained from the University of Queensland. One of the outcome measures was the presence of multi-site interfering symptoms in the previous year, defined as ache, discomfort, or pain at 3 or more of 6 anatomic sites, which included the neck, shoulders, elbows, wrists, and hands, upper back, and low back, that prevented sonographers from doing usual home or work activities. Another outcome measure was disability levels associated with neck pain in the past week, quantified using a percentage of the Neck Disability Index. Risk factors were measured using standardized questionnaires, including individual characteristics, work-related physical and psychosocial factors, for example, social support, psychologic factors, such as pain catastrophizing, which refers to a negative emotional response to pain, and fear avoidance beliefs, referring to avoidant behavior based on fear of pain, and comorbidities. Multivariate binary logistic regression was used to determine which risk factors explain the presence of multi-site interfering symptoms, while multivariate linear regression was used to explain neck-related disability. Data analysis were conducted using R version 3.4.2. Statistical significance was set at 0.05. After removing duplicates, 430 of the 437 eligible responses were obtained. Of these, 86 or 20% had missing data, leaving 402 available to analyze the prevalence of MSK symptoms and 344 for regression analyses. Participants, of whom 80% were women with a median age of 41 years, had 12.4 years of sonography experience and performed sonography for 28 hours a week across echocardiography 25% and general sonography 75%. Differences, mainly in work physical characteristics, were found between cardiac and general sonographers, reflecting the divergent work characteristics of these sonography types. Findings regarding MSK symptoms, neck-related disability, and risk factors for cardiac and general sonographers were similar to those for the whole sample. Almost all sonographers, 98%, reported at least one symptomatic site, and 57% reported interfering symptoms in the previous year. About 86% of sonographers had multi-site MSK symptoms, and 20% experienced multi-site interfering symptoms. The most prevalent body sites with interfering symptoms were the neck at 32%, shoulders 34%, followed by the low back at 22%, wrists and hands 17%, upper back 16%, and elbows at 8%. The median score on the Neck Disability Index in the past week was 10%, with 55% of sonographers reporting at least mild disability. The final logistic regression model showed that the presence of multi-site interfering symptoms was significantly associated with pain, catastrophizing, and fear avoidance beliefs. The final linear regression model demonstrated that higher neck-related disability was significantly associated with the presence of medical or traumatic history, lower vigorous physical activity, higher ergonomic risk, lower social support, higher depression scores, pain catastrophizing, fear avoidance beliefs, frequent eye symptoms, and numbers of coexisting interfering MSK symptoms. This model explained 53% variance of neck-related disability in the past week. In summary, the one-year prevalence, 98%, of MSK symptoms in sonography was alarmingly high. 1 in 5 sonographers reported multi-site symptoms that interfered with their work or home activities. These prevalence rates may be even higher as our sample, sonographers only working greater than or equal to 4 hours a week, may not have captured sonographers working limited hours because of MSK pain. Current guidelines for sonographers to manage MSK pain and disability focus on ergonomic interventions. However, ergonomic interventions, including workstation adjustment, use of ergonomic equipment, training on proper work techniques, and posture school were found to be of limited benefit in addressing MSK symptoms among workers. This could be because MSK symptoms are associated with complex biopsychosocial mechanisms beyond ergonomics. Our data indicate that other factors including pain, catastrophizing, fear avoidance, beliefs, depression, lower social support, lower vigorous physical activity, and comorbidities must be considered in designing prevention and management interventions for this population. Development in partnership with sonographers, employers, and other stakeholders, multimodal interventions incorporating strategies tackling psychologic distress, improving workplace social support, promoting vigorous physical activity, and addressing comorbidities such as eye symptoms may be proved to be effective in enhancing the MSK health of sonographers in future research. The following article is an audio-long read of a clinical investigation appearing in the December 2020 issue of the journal. The article is entitled Diagnostic Performance of TEE and Cardiac Computed Tomography in Infective Endocarditis by Islam Sifawi et al. Infective endocarditis is a serious infection of the endocardial surface of the heart that most commonly involves the valves, and it requires urgent treatment including cardiac surgery in 75% of cases. In addition to microbiological investigations, the non-invasive imaging evaluation is a cornerstone of IE diagnosis. Identification of infective endocarditis, or IE-related valvular and or paravalvular lesions, is one of the two major Duke criteria. The first-line modality includes echocardiography using both transthoracic echocardiography and transesophageal echocardiography approaches because they provide a dynamic, precise, and complementary analysis of the valves. However, TEE accuracy for detecting local and regional complications may be limited, especially in patients with prosthetic valve endocarditis. Cardiac CT is recommended to detect valvular and mainly paravalvular lesions in patients with prosthetic valve endocarditis or when echo is inconclusive to accurately assess infective endocarditis-related cardiac lesions for better surgical procedure planning. However, most studies evaluating the performance of cardiac CT for the detection of infective endocarditis include a relatively small number of patients. and the surgical confirmation was not systematically performed in these series. Therefore, the aim of our study was to compare the performance of TEE and cardiac CT in the detection of endocarditis-related cardiac lesions according to surgery findings in a large series of patients with a definite diagnosis of left-sided endocarditis based on the modified European Society of Cardiology Duke criteria. Methods in brief. 68 patients with a mean age of 63 years with a definite diagnosis of left-sided endocarditis according to the modified ESC Duke criteria on both native and prosthetic valves underwent TEE and cardiac CT before surgery. The presence of valvular lesions such as vegetation or erosion and paravalvular lesions such as abscess and pseudoaneurysm were compared between both modalities. Perioperative inspection was used as reference. Results in summary. TEE performed better than CT in detecting valvular endocarditis-related lesions. The TEE area under the curve was 0.881 versus 0.720 for CT, and was similar to CT with respect to paravalvular endocarditis-related lesions. The ability of TEE to detect vegetation was significantly better than that of CT. The maximum size of vegetations was moderately correlated between modalities. CT exhibited higher sensitivity than TEE for pseudoaneurysm detection, but was similar with respect to diagnostic accuracy. Discussion. In this study, TEE was superior to CT for detecting valvular endocarditis-related lesions, while the ability to detect paravalvular complications was similar between both modalities. Compared with TEE alone, a combination of both modalities did not significantly improve diagnostic performance. Both TEE and CT exhibited lower diagnostic performance in prosthetic valve endocarditis than in native valve endocarditis. In the present study, we observed that CT performed similarly for the detection of vegetation compared with previous studies, which report a rate of between 70 and 96%, except for one study where the low reported rate of detection, 16%, was mainly related to the single-phase ECG-gated protocol and the use of thick CT sections. As expected, TE performed better than CT for the detection of vegetation, probably due to its higher temporal resolution. In contrast to previous published data, our study noticed only a moderate correlation between TEE and CT for the evaluation of the vegetation size even in vegetations greater than 10 millimeters. Interestingly, the diagnostic performance and especially the specificity of CT tend to be lower in the mitral than in the aortic valve. This difference may be due to two specific states of the mitral valve, the dynamic motion during the cardiac cycle and the complex anatomy, which includes the subvalvular apparatus and non-pathologic focal leaflet thickening, which can lead to misdiagnosis, false positives or negatives. TEE also better detected leaflet erosion compared with CT. Such difference in performance was previously observed and may be explained by the contribution of color Doppler during TE that helps to confirm leaflet erosion. The prevalence of paravalvular extension of endocarditis is a serious complication that requires cardiac surgery because of worse prognosis, but its diagnosis by TEE may be challenging, mostly in prosthetic valve endocarditis cases. The previously reported sensitivity of TEE for abscess detection was often less than 60%, while it was significantly better in our study, 73%. This difference may be explained by the systematic utilization of 3D reconstructions during TEE that enhanced anatomic understanding of adjacent structures, and also by the unique design of our endocarditis unit. Indeed, all patients with a suspected or confirmed endocarditis in our hospital are admitted in this unit to undergo a complete evaluation, including transthoracic echo and TEE by a dedicated team. Previous studies also reported higher performance of CT compared with TEE for abscess detection, while the combination of both modalities improved the diagnostic performance. In our study, CT performed well, but was similar to TEE in detecting abscess. Both techniques performed worse for the detection of abscess in prosthetic valve endocarditis than in native valve endocarditis. The difference was more important for the CT, probably because of beam hardening artifacts that decrease image quality. Interestingly, both TEE and CT sensitivity for abscess detection was lower in mitral than in aortic endocarditis, which may be related to unclear imaging delineation between mitral annulus and myocardium. The combination of both modalities did not significantly improve diagnostic performance. Conversely, CT performed very well for pseudoaneurysm detection with 100% sensitivity, higher than TEE, which was at 67%, and missed 2 pseudoaneurysms. Such high performance has been reported in the literature. Our results apply only to surgically confirmed endocarditis. We believe that the similar performance of TEE and CT for the detection of paravalvular complications suggests that for this indication, the two techniques can be considered equivalent. The CT can be of value to detect paravalvular complications of endocarditis when TEE is equivocal or not feasible. However, its use in all comers remains to be defined, especially in light of the limited improvement of diagnostic performance when TEE and CT are combined and radiation exposure is taken into consideration. Some limitations have to be mentioned. First, the study was conducted in a single institution, and multi-center studies are required to confirm such results. Secondly, only endocarditis patients with a surgical indication were included to provide a robust confirmation of TEE and CT findings. However, these patients could have more extensive endocarditis lesions than all comers, which may lead to overestimating the performance of both modalities. Third, bias may have existed during the analysis of images because the readers of the TEE and CT images knew that examinations were performed in patients with a definite diagnosis of endocarditis. It would have been interesting to include cardiac imaging performed for suspicion of endocarditis to avoid this bias and to evaluate the ability of CT to rule out endocarditis. Nevertheless, our aim was to have surgical confirmation to increase the confidence in our results. It would have been interesting to interpret TEE and CT images using the clinical and biologic data, but we decided to be blind to it in order to be more reproducible and not influenced by physician experiences. Fourth, with such a small number of endocarditis-related cardiac lesions, there is a high likelihood of missing a significant difference between techniques. Fifth, it is possible that relevant information was not recorded during the initial TEE that may have affected the diagnostic performance. However, the systematic 3D acquisition with a subsequent analysis may have limited this problem. Finally, only left-sided infective endocarditis lesions were included in our study because of the difficulty in analyzing right cavities on CT due to inhomogeneous opacification, frequently observed, and imaging artifacts induced by leads of cardiac devices. Conclusion. In patients with a definite diagnosis of left-sided endocarditis according to the modified ESC-DO criteria, TEE performed better than CT for the detection of valvular endocarditis-related lesions, while the ability to detect paravalvular endocarditis-related lesions was similar between the two modalities. In this audio, I abbreviated the methods and results. However, the details of this paper can be fully appreciated in the December 2020 issue of the Journal of the American Society of Echocardiography. The authors also describe their unique workflow where both transthoracic and TEE are performed in special units for patients that are being assessed for endocarditis. Finally, there are several beautiful figures which show examples of lesions seen both on cardiac CT and compared to TEE. Thank you for joining the weekly JASE podcast series. We look forward to welcoming you again next week.